Hi there, welcome to Allume's Corporate Compliance Workshop. So today I want to talk to you about a couple of things. First, I want to discuss the compliance issues in home care, identify some things that we want to make sure we do correctly, especially in marketing. I want to review with you some federal, state, and local regulatory standards and define the components of our Allume corporate compliance program. And lastly, articulate the procedure for reporting any concerns that you might have. So compliance, what do we mean by compliance? Compliance is in the word, it says comply. So we're trying to comply with a set of rules. And so we have all kinds of rules as a home health agency. We have rules associated, you have rules associated with yourself as a nurse, a licensed nurse, or a CNA, or an OT/PT, speech therapist, social worker. There's rules associated with being a Connecticut licensed home care agency, or a Medicare accredited home health agency. So our compliance program is in place to help to ensure all of our rules are followed. And it's all meant to protect you, it's meant to protect the agency, our patients, and the people who pay us, our Medicare, Medicaid, and private insurance providers. So the Patient Protection and Affordable Care Acts of 2010, this put into place some new rules that helped us to make sure that home health agencies would be compliant, and it was put into place around prevention of fraud, waste, and abuse. It's also about detecting any kind of criminal, civil, or administrative violations, and it's also meant to put in place quality of care. So fraud, waste, and abuse are things that we look for, things that we want to make sure aren't happening. Waste is here's the definitions. Waste is usually an unintentional overutilization, underutilization, or misuse of resources. So, for example, if you're overusing PPE, but it's not intentional, that could be waste. If you're using lots of notes, so if you're using lots and lots of pages of the narrative note, if you're on paper, and it's unnecessary, that would be waste. Abuse covers practices that are inconsistent with sound fiscal, business, or medical practices that results in additional cost, improper payment, or payment for services that fail to meet the standards. So this could be things like having services out in the field where a person is receiving nursing services, but perhaps they are not really skilled services, right? And really it might be time to discharge a particular nurse. That's considered abuse. Fraud is the intentional deception or misrepresentation made by a person with the knowledge that deception or misrepresentation could result in a benefit to them. So, for example, clocking in and out and not going to work, that's fraud. It's very, very legal. You'll get yourself into lots of trouble getting paid even still. Fraud's also if you're working and you're sleeping, right? That says I'm working, I'm taking care of somebody, and I'm sleeping. That's also not a good idea. So these are the three different things: fraud, waste, and abuse. Compliance and ethics. So compliance involves what is mandatory under the law. It has specific rules that govern what to do. Ethics refers to what is right and what is wrong. So it answers the question, should I do this? Versus compliance, which answers the question, can I do this? So our corporate compliance program is really infused with both rules and ethics, doing what's right and following the rules. So our ideals. So being remarkable is at the heart of our compliance program. And so are many of our core values. So that commitment to high standards of integrity and ethics, that's an important piece. We look to have everyone demonstrate character, everyone to be acting ethically, morally, and legally. And we're always aiming to elevate the quality of care. Again, that's an ethical standard. It's less of a compliance thing. It's not a rule so much as it's part of ethics. Doing the right thing all the time is one of our mantras. And speaking up when something violates our ideals, our policies, our regulations, or law is something we ask you to consistently be willing to do. And we hear from you when things are not going the way they should, and you point it out to us whenever it comes up. So we appreciate that. So what are the components of our compliance program? So first of all, we have a written set of policies, procedures, and standards of conduct. And so if you were to come into the office, we could show you all of our policies, or many policies, hundreds. And they're all written and they're approved regularly by our governing authority. A designated compliance officer and a compliance committee. So we have a compliance committee and a compliance officer. A compliance officer happens to be our administrator, and we have a compliance committee that involves different members of the team, administrative team, and we meet on a quarterly basis. Effective training and education conducted at time of hire. And so when you come on board, right, you have 12 plus hours of initial onboarding training. So that is required. That's part of our compliance program. Effective lines of communication that keep employees abreast of the compliance program. So we have our in-services that take place in our town halls, emails that come out that give you notices and of policies, etc. So these are all ways that we communicate our compliance program. Well-publicized disciplinary guidelines for responding to and addressing compliance concerns. So again, these are things that we do through our in-services, we do through emails. We also, of course, distribute everybody the employee handbook. It's also available online. So internal monitoring and auditing is conducted on a regular basis, and this is true. We have all kinds of internal systems that log any kind of incidents, complaints, events, ethics issues that come up, and then we review them both within our internal team, but we also share them externally with our governing bodies. So our professional advisory committee and our governing authority, and we share those regularly. And the last thing here is prompt response to detected offenses and development of corrective plans. So if something comes up, then we have a process in place through our policies and procedures that tells us how we need to respond and who needs to be informed. So these are all parts of our very exciting compliance program. So healthcare fraud's a big deal, and you can read this slide and you can get into it. There's $170 billion annually of Medicare and Medicaid spending represents fraudulent billing. So there's a huge need to make sure that there is no healthcare fraud. Non-compliance consequences. So we are very, very, very conservative and cautious here. And because if we have any issues of fraud or non-compliance, it can come back to really bite us. It includes non-payment of claims, take-backs of previously paid claims. So if something were to happen and they could look back over time and want to take back money from months or years past, there could be fines, there could be a loss of our license or accreditation. It could even be criminal liability or civil liability. So we take very seriously all of the corporate compliance rules around how we conduct business, and by all means, we absolutely avoid anything that could be related to fraud. Heat and strike. So in 2009, the Department of Justice and Department of Health and Human Services created the Healthcare Fraud Prevention and Enforcement Action Team, called HEAT. That's a lot. And they also created the Medicare Fraud Strike Force, and it was intended to prevent fraud, waste, and abuse in the system and to crack down on individuals. And certain areas of the country really saw huge hit. Like Texas, for example, was an area that had a lot of different issues with fraud, and they had to make a lot of changes to their systems there. In Connecticut, we have a pretty tight system already. We've had a tight system here for a long time. Department of Public Health and DSS, Department of Social Services, that is our Medicaid body, is pretty on everybody. There's not much fraud going on in Connecticut. But just to know that these are some pieces that have been in place. since 2009 that help to ensure that fraud does not take place. So fraud fighting efforts, background checks, right? We're required to do background checks on all new employees. We have revalidation of all of the Medicare suppliers. So every 3 years we are required to be revalidated as an organization. They also require growth pattern monitoring, so comparing different agencies against each other in terms of how, their geographical location, and they look for things that might be off. Strike force teams, so implementation of strike force teams that used data to identify high billing levels of fraud-prone areas. Again, I mentioned that Texas was an area, in specific areas there. Predictive modeling, so clinically based predictive models which look at major disease categories, and so making sure that, for example, in Medicare, that you get paid more in the Medicare area. When you're billing Medicare, you get paid more depending on what the person's diagnosis is. So if they find that a particular agency is using diagnosis codes that are unusually high in some areas, then they might come and look at it. The other thing they're doing is electronic visit verification. That started to be rolled out here in Connecticut, and I expect that will continue, and that will, where you have to validate when you arrive, either by calling from a landline and saying, yes, I'm here at this particular address, or using GPS. So these are some of the things that are in place. Compliance categories. So compliance issues arise when a home care provider issues a fraudulent claim. And so in order to ensure that claims meet all home health care compliance requirements, they must include billing for services that were rendered as indicated on the claim, billing for services provided to qualified patients, and billing for clinically appropriate care. So all those pieces have to be in place. Has to be the right kind of service, has to be to the right kind of patient, and it has to be to patients who actually need the care. So billing for services rendered. The most common compliance issue in home care occurs when services are billed that were never rendered. So billing for services that weren't made, services without physician orders, that's a very big one. Billing for services provided by staff who are not licensed or qualified. So somebody goes out and delivers the care, but they don't have the license. Or billing for services at a more expensive rate than was actually performed. So sending out an LPN, but billing as an RN. So these are all some of the things that can fall under that catchment. Billing for services to qualified patients. All right, so in order to bill for home care and hospice services, the patient must be qualified to receive those services. And so those qualifications all fall under what they call the Medicare conditions of participation. So billing for services made to patients who do not qualify for the conditions of participation. So they're not a Medicare patient, for example, or they're not homebound if they're a Medicaid patient, would mean that they do not qualify for the services, and that would be considered fraud. So to qualify for home health care, the patient must be under the care of a physician, right? The patient always has to have a doctor, and we always provide care under signed physician orders. The patient must be homebound, and this is specifically for Medicare. It's not for Medicaid or for private insurance, but for Medicare, homebound status is required. So if somebody is receiving home care services and they're not homebound, we can't do the service. The patient must have a need for a skilled qualifying service, so like nursing, physical therapy, speech pathology, or some other occupational therapy. Skilled nursing must be part-time and intermittent. So for Medicare, not Medicaid, but for Medicare, nursing is the skilled service. Qualifying must be one visit, more than one visit must be ordered, and the service must be intermittent or occurring less frequently than daily, unless a predictable and finite endpoint is established. So it's so the continuous care services would never be billed to Medicare, because they only do Medicare only does part-time and intermittent. And services must be medically necessary. The person must need the services, and it must be written in the plan of care. So then we want to talk here about utilization risks. So non-qualified, medically unnecessary services are also inappropriate. So scheduling extra unwarranted visits, right? So maybe the patient only needs 6 skilled nursing visits, but we send them out 8 times. No, can't do that. Requesting extra therapy visits to achieve a higher therapy threshold payment, not allowed. Performing medically unnecessary recertifications, again, not allowed. So it's really always based on the result of a comprehensive assessment. And unless there are valid documented reasons to support services, increasing or decreasing utilization for payment purposes should never, ever happen. So it's important for all you case managers, RNs out there, that these are examples of how you can fall out of compliance. So clinically appropriate care. So in order to appropriately bill for home care services, Medicare requires that clinically appropriate care be provided to all patients. So this examples are providing care based on nationally recognized clinical criteria, right? Providing services that have been ordered by a physician, providing individualized care based on an assessment, we talked about that, providing services in the amount, scope, and duration. So I want 2 skilled nursing visits per week, and I would like to send out a home health aide, 3 hours on 3 days a week as well. So the amount, scope, and duration based on generally accepted standards of practice. Ensuring clinicians are qualified to safely and effectively provide the care. That's something that we have to always do, which is why the in-services are important, why we do competency evaluations, while we do your performance appraisals. So providing cost-effective care, right? We want to provide care in a way that is reasonably priced. So not having too many people involved. In fact, effectively managing transitions between care settings. So this is also considered very important and part of the conditions of Medicare participation and also Medicaid, is that you help. If you're bringing somebody home from the hospital, you're going to communicate. If you're the case manager, you're going to communicate back to that facility, perhaps Hospital for Special Care or Connecticut Children. You're bringing them home. You're going to communicate with them in advance to make sure you know what their needs are when you bring them home. Just as if they were to go back to the hospital for some reason, that you would be on the hook to provide that good information back to that hospital or to another facility, rehab facility, or whatever was necessary to make sure that they can transition safely. And then recertifying patients only if they continue to qualify for services. So we have a lot of patients here, our continuous care patients, who continuously recertify, and we always have to make sure they continue to qualify. And you probably don't know this, but in the office, we are constantly, every time we get reauthorization to send out these patients for reauth through Medicaid, we are constantly having to prove, based on the documentation in the field, that this patient has a clinical need and that we are providing a real service. So if you don't document, then we can't provide evidence that we're doing something of value and that we should continue. And then it's appropriate to discharge patients who no longer qualify for home health or hospice services. So documentation risks are really a big deal, and this is really where compliance comes down, and this is where it happens most frequently, where the documentation isn't where it should be, isn't as precise as it where it should be, isn't including what it should include. Things are forgotten. So claims may carry a compliance risk if they are not supported by sufficient documentation. And this is why everybody, whether you're a home health aide or you're an LPN shift nurse or you're a case manager or a clinical care manager, that your documentation should reflect accurate and complete clinical assessments. So if you're a nurse, you're going in and you're always doing a head-to-toe assessment. Make sure you're documenting that. Errors should be corrected based on our policies. Documentation should be appropriately signed and dated. Clinical documentation should never be altered, defaced, or falsified. Assessment results should not be inflated to justify services. Under no circumstance should a physician's signature or patient signature be forged. That is a big no-no. A person who falsifies documents not only faces healthcare fraud, but other illegal acts. So you cannot do that. It's not good for, it's illegal for the company. We can get in trouble and you can get into trouble. Big time. Kickbacks, another area. Can't do it. Government is interested in how healthcare providers market their business and sell their services. So kickbacks include payment of remuneration to induce or reward patient referrals or the generation of business involving any item or service that's paid for by Medicare and Medicaid. So any kind of services that Medicare and Medicaid provides, like nursing services, any kind of drugs or prescriptions or supplies. So remuneration is anything of value, including cash, gifts, office space, free or discounted services. So we can't say to hospital for special care, hey, give us referrals of patients and we will give you something back. Can't do that. That's illegal. The anti-kickback statute is a criminal law that defines, prohibits, and penalizes kickbacks. Criminal penalties and sanctions for violating this are big. They can include $50,000 per kickback plus 3 times the amount of the remuneration. So it could be major. So if we have a patient who comes to us and is with us 23 hours a day, 3 times perhaps whatever we might have paid we might have received as payment for those services. If you ever find yourself saying the physician will only give us a referral if ... more likely than not, it's some kind of illegal inducement. So we at Allume don't have anything like this set up. We're very careful about it, but just make sure in your life that you're aware of this kind of thing. Risk areas. So there are many areas where marketing related violations can occur. So giving information or incomplete information about home health and hospice regulations and the scope of services could be an issue. Making inappropriate or unattainable promises to referral service. If we were to tell referral source that we could 100% cover every single shift, that would be inappropriate. Offering unethical or illegal inducement kickbacks, of course, can't do. Offering or providing free staff, rental payments for office space, meals and entertainment, etc., not allowed. Offering or providing services for free at a reduced rate, to a potential or actual payment, you can't do that either. Offering payments to physicians to sign orders or plan a care, no, can't do that. Improperly soliciting patients who don't qualify for home health or hospice services, and or who are not homebound. So just getting people in who don't really fit and then billing for the services. Establishing illegal compensation programs for marketers and employees that offer incentives for the number of referrals obtained, hospice lengths of stay, or for visits made. So we don't do any of that, but it's not allowed. Participating in unlawful activities that improperly influence referrals to select a home health agency. Again, you cannot do that. Slandering competitors, can't do that. So these are all under that anti-kickback statute. Safe harbors. So the federal government provides safe harbors for 25 different business relationships. So safe harbors are payment and business practices that, although they potentially violate the anti-kickback statute, are not treated as offenses. Okay, so safe harbors are there more or less exceptions. So there's the marketer's safe harbor. So while compensating people for referrals would routinely be a kickback, a safe harbor exists that allows marketers employed by the agency to receive bonuses. So if I have a marketer who's a W-2 employee and the bonuses are defined within agency's policies, then we can do it. They should be part of the employee goals and form the basis for the annual evaluation. So we can do it carefully within this concept. acute and post-acute providers. So a second example of a safe harbor involves the ability of a health system that have both acute and post-acute components to refer patients to their home health and hospice agencies. So this would be, for example, like the Hartford healthcare system. They have the hospital, and then they have also the home care. They have a safe harbor where they can refer patients from their hospital to their home health agency. Anti-inducement laws impose civil monetary penalties against any person who offers inducements at a level that is likely to lead to a referral of a person participating in the healthcare program. So the OIG has defined that the level that could lead to a referral are inducements of more than $10 per item or $50 in aggregate. So we can give small gifts, but we can't give big gifts. So we could go and we could bring a tray of donuts, and that would be okay. But we couldn't buy somebody a car, for example, to sort of get them to come to give us referrals. Stark law. So the physician's self-referral law, commonly referred to as Stark law, makes it illegal for a physician to refer a patient to an entity where she has or he has an immediate family member has a financial relationship. Okay, so a financial relationship can involve ownership, investment, or a structured compensation. So if a physician were to own part of Allume, for example, then they would not be able to refer patients to Allume. The violation impacts both the referring physician, so the physician who would be signing and owning, and also the entity. So any claims filed as part of the illegal relationship would be considered false claims and subject to additional penalties. So doctors have to be very careful about the kind of entities that they are involved in, and they have to make sure that they're not benefiting financially from those relationships. Acceptable marketing activities. To build a business, home care agencies need to elicit the attention of physicians and referral sources. So yes, we can do that. The task has to be accomplished legally, ethically, while following requirements of anti-kickback statute. Best way to do this is through high quality services, share stories, and create positive patient experiences and produce positive outcomes. So that's what we try to do. So when we're marketing to a hospital for special care or to a doctor's office, we are focused on here's how we do what we do at Allume, and here's how we are remarkable. We don't do it by getting them tit for tat, right? Oh, we're going to give you tickets to see the Patriots if you'll give us a referral. We don't do that. That's not allowed. False claims. A false claim is a fraudulent claim knowingly filed for payment. So knowingly is defined as careless indifference or reckless disregard. So any person who violates, frauds, fails to report the observed wrongdoing is also subject to any penalties. So we want to make sure we don't have any false claims. We also have the whistleblower cases and situations. So it's making sure that if you see something going on that looks wrong, then you should report it. And if you do, you're protected. That's basically what the whistleblower policy is all about. So conflicts of interest, all of you and me, we are all bound by conflicts of interest. So all employees must avoid situations where personal interests or outside activities of influence could appear to influence daily work decisions. Conflicts of interest are other areas that agencies and employees can demonstrate unlawful compliance. So a home health employee is part owner of a durable medical equipment vendor that does business with the home health agency. That could be a problem. An employee uses a company copier to print her neighbor's monthly newsletter. That's a conflict of interest, and that's a problem. A home health aid employee accepts football season tickets from a company that has a telephone hardware contract with the home health agency. Again, not allowed. So these are all conflicts of interest. You have to look out for them. The best defense for a home health organization is a stringent corporate compliance program, which we have. The expectations are that employees will do the right thing for the right reasons all the time, Employees will not cut corners. Employees will act honorably, ethically, and lawfully. Employees will care for patients in the best way possible. And if a problem arises, that we ask employees to report the issue as quickly as possible. Okay, so then we have leadership responsibilities. Home health can be held accountable for non-compliant actions of its employees. Leadership must take specific actions to protect the company, our agency, our employees, and our patients. So we always have to have our policies in place. We always have to be going through and measuring them and seeing that they're working. We have a policy regarding gifts and what can be offered to referral sources and patients. Documenting, we want to make sure that all of our policies that are related to all of our employees are documented and signed. We want to certify that employees have been educated on compliance and organizational expectations, like we're doing right now. And we want to perform ongoing audits of high-risk areas to detect and correct compliance areas. So we have what's called a QAPI program, and that's a subject for a whole other thing, but that's how we look to see where we have areas of quality or compliance issues, and we then create projects, performance improvement plans, PIPs, where we look to make sure things get better. Reporting compliance concerns. So confidentiality is protected to the fullest extent, so you can always reveal any kind of issues that are coming up. When a compliance concern is identified, the recommended first thing to do is to go to their manager, report through the proper chain. So if you can't go to your manager because you don't feel that it's okay, you can always call into our confidential phone box where your concerns can be addressed, and I will listen to the messages. In situations where the employee does not feel comfortable or safe reporting a concern to the organization, you can also make a report to Medicare or the Office of Inspector General. So these are the places that you can report compliance concerns if you're worried about what's happening. I hope that you never do have these issues, but this is how you do it. So if you have an issue, this is how you report to Medicare, Medicaid, or how you report to the Office of Inspector General, which is OIG. So in conclusion, the government has made clear corporate compliance is critical. Compliance risks and healthcare fraud are tremendous problems of great financial magnitude, so we have to keep an eye on that because we want to steward our national and local resources and dollars for healthcare. And as baby boomers approach retirement, the government will step up its monitoring efforts, right? Because more and more people are needing the system, and so they're going to be watching more and more to make sure everybody's compliant. And consequently, healthcare providers will have to remain vigilant in compliance. We will all have to keep on our toes about this all the time. So that is it. That's all I got for you today. Thanks for being here and being a part of this corporate compliance conversation. I hope you have an absolutely wonderful day, and go make the world a better place.